like Ange said, my name's Nicci. I've got my colleague Sarah Lewis with me. We both work in RCI in Birmingham. So just a little bit of background. RCI, as a laboratory, handle hospital reference investigations. We handle antenatal reference investigations, ABO incompatible transplant investigations, which are both for donors and also for recipients involving the titration of ABO-I antibodies. Also phenotyping and genotyping for patients where phenotyping is not possible. So what might start off as a simple investigation request might not always stay that way. And it's not just antibodies to high frequency antigens that may require provision of rare cell units.
Okay, so for case one, we received samples from a 36-year-old antenatal patient. Now, normally for our pregnant ladies, we get an initial booking sample to test at 10 to 16 weeks, but this lady was a late booker. We had no previous antenatal history on this lady. So according to BSH guidelines, we test. So we do the ABO group, the D group, the RH and K phenotyping, and antibody investigation by IAT and enzyme IAT. If this is negative, we repeat at 28 weeks, and if 28-week repeats negative, there's no further testing. But if the screen's positive at any point, we identify the antibody, we use those results to dictate the further testing to determine the level of the antibody and the likelihood of hemolytic disease to the fetus and newborn.
So initial results from the automated IH1000 platform. If we have a little look, this is the printout from the grouping result and from the extended RH and K phenotypes. So can you spot anything unusual with these pictures? Each of these cards in isolation is nothing really very special, but when we consider them together for one patient, we can see that the ABO group is B, the D group is D negative, and then the extended RH and K phenotypes, what looks like an R1, but obviously the patient is D negative. So this is in itself an unusual result.
Okay, so the results that we've got for this patient indicates that there are probable R', R'. So why do we say probable? There are 8 RH haplotypes that have the potential to generate 36 different genotypes. Using the typing results that we have, we could only generate possibly 18 of those phenotypes out of the potential 36. So only 8 of those CDE combinations together represent one single genotype. The other 10 sets of different results can generate anywhere between 2 and 6 possible genotypes. So you can never be certain unless you have the genotype results in front of you. So we use probable because it's a best guess aligned with the gene frequencies in a given population. And it's important to remember that the probable phenotype can actually differ from the true genotype.
So we've focused so far on the fact that the patient's identified as a rare phenotype. The antibody identification results showed that an anti-little c antibody was detected by both IAT and enzyme IAT. And the picture to the right of the slide shows our anti-quant Mark II analyzer, whereby we would the patient sample would undergo quantification to enable us to obtain the anti-little c level that's present in the patient sample. So in accordance with the BSH guidelines, the current practice in the UK is to monitor these antibodies, anti-little c and anti-D, by continuous flow analyzer quantification. And this is a more reproducible and thought to be less subjective than manual titration methods. And there's also an international standard available to enable both control and calibration of the technique. So it's worth noting that the technology used with the anti-quant Mark II, although it's a fairly new machine to us in the lab, it's the same technology principles that we've been using for the past 50 years. So just in addition, the clinical significance of the level given, it's a 0.3 international units per mil has been identified in this sample, and HDFN is unlikely when the anti-little c level remains below 7.5 international units per mil. So we need to, sorry, we're just looking at the chats. Can you guys see this slide that says case 1 still? Ange?
Yeah, I can still see it. Fine.
Okay, that's all right. The chat threw me then, sorry. Okay, so the clinical significance is that it's unlikely when the level remains below 7.5 international units per mil. The advice that we give on the report is also in accordance with BSH guidelines to repeat testing every 2 weeks until delivery. So it would be every 4 weeks prior to 28 weeks. But as Sarah's already mentioned, we didn't see this lady until she was 28 weeks pregnant. We would also recommend paternal phenotyping and or fetal genotyping that will aid clinical management of the case. And in addition, because we've identified the patient's D negative, we also advise that the patient should receive both antenatal and postnatal anti-D prophylaxis too.
Okay, so when we came to the reporting of this case, once it had been reported to the hospital, we also contacted our medical department, so Dr. Anand and Emma, to make them aware of this lady. As she's got a rare RH phenotype, there could be issues with blood provision. So by giving them notice, we can liaise with them and arrange for suitable donations to be sourced nearer to this lady's delivery date. So at that point, a letter was sent to make the hospital aware of this lady's phenotype, so we could then make plans nearer her to delivery to ensure there was supply of units if required. So this lady was already sensitised and she'd produce 1 antibody. If she made more, then blood provision would become more problematic. Okay, hopefully you can see the next slide. We had a subsequent sample we received at 35 weeks. So as it was a subsequent sample, we had a history, so it gave us a starting point to go from. So if you can see the panel sheets, and apologies if you can't, we have our standard panel, which is a panel of cells with a mix of RH phenotypes, which demonstrates the presence of an anti-little c with some extra reactions. So what we would do with that is we would then put that plasma up against a second panel of R1 cells with just 1 RO cell on to prove the little c was still active there. And if you can see the R1 panel, which is the yellow one on the right hand side, you can see that the little c is the stronger reacting cell, cell 5, the RO, but there's also a low-lying antibody also there. It's weaker reactivity, but it's showing that there's a presence of another antibody. So what we do is we look at what all those cells have in common. So they're all R1, they're all D positive. The patient is D negative. Could she have an anti-D?
So it's worth noting that the patient had no recent history of anti-D prophylaxis that we were aware of. So the next question is, how do we distinguish between the antibodies present and prove the specificities that are there? So we can utilise absorption techniques. So traditionally, alloabsorption is used to remove autoantibody from a patient sample, which then allows us to detect any underlying alloantibodies. We use a paired enzyme treated cells that are provided by reagents in Liverpool, and these have got opposing phenotypes. We use an R1 cell and a little r cell, and there is also an R2 cell provided too, but this isn't used in the vast majority of cases. So for this patient, what we're trying to do is to use the R1 cell to remove the anti-D that we think is present and just leave the anti-little c in the patient's plasma, and to also use a little r cell to remove anti-little c and just leave the anti-D that's present in the plasma. So the picture that's shown there is just illustrating how the technique is carried out. So we start with the native patient plasma, and we've performed subsequent absorptions by incubating 1 volume of patient plasma with 2 volumes of reagent red cells. And this is called double bulk absorption, and it's thought to be more effective than a 1-to-1 ratio. So following each incubation stage, the cell and plasma mix is then centrifuged and moved along to the subsequent tube. We're then left at the end with absorbed plasma. You may have seen this referred to on your RCI reports as modified plasma. And we can vary the number of absorptions to a degree dependent on the strength of the autoantibody present that we're trying to remove. So here are the results following the absorption. We use the absorption, as we said already, to try to prove the presence of an anti-D. So the R1R1 treated plasma has left the anti-little c visualised within the panel, and the little r plasma has left the anti-D visualised. But it's worth noting from the panel that the anti-D was just there weakly and it wasn't identified by IAT. So we panelled by enzyme IAT, and there we could see that it is weakly present in cells 1, 2 and 3. So the next step now for investigation of this patient was to perform the quantification with the native plasma on both channels of the quant to enable accurate measurement of both anti-little c and of the anti-D antibodies.
So as Nicci's just said, we detected an anti-little c and an anti-D in this patient sample. So the anti-little c quanted at 0.4 international units. So not a significant change from last time and still in the low risk category for hemolytic disease of the fetus and newborn. So BSH guidelines would be to test every 2 weeks to delivery, as this lady was post 28 weeks, to monitor the antibody levels and to identify if any additional antibodies have been produced. And at delivery, we would advise for a core DAT to be performed and the HB and the bilirubin levels of the baby checked. If that DAT was positive, it can be an indicator of HDFM, but it's not diagnostic on its own. And we can also use a red cell eluate if the DAT is positive to elute that antibody and confirm the specificity. For the anti-D, as we've said before, this lady had no history of prophylaxis, and at a level of 0.1 international units, we can't distinguish between immune and prof at this level. So the clinical information makes a big difference to us. Due to the level, we would say that the patient should still receive antenatal and postnatal prophylaxis. And we'd also ask for a paternal sample for phenotyping and a sample fetal genotyping. So just to show you on the report, this is what one of our reports would look like. So we cover the antibodies that we found and their significance, the clinical advice that we've given that the lady should be in the care of a hospital obstetric unit. That advice changes as her risk level increases, and that she should continue to receive antenatal and postnatal anti-D prophylaxis. The repeat sampling requirements, any further actions, and that we would recommend that we have samples for paternal phenotyping and fetal genotyping. We've also got an extra comment in the blood selection to say, in view of the difficulty of finding blood of this type, please give as much notice as possible if requesting blood. And that's just a heads up for the hospital transfusion laboratory to say, this is a bit out of the ordinary. So if you are likely to need blood, we need some notice, as it's not likely to be available just off the shelf. And just as an aside, we did actually receive a paternal sample for phenotyping, and the partner grouped as A, D positive, R1R1, K neg. So homozygously positive for D and heterozygously positive for little c, but we never received a fetal genotyping sample.
So like Sarah's just highlighted, we do highlight on the RCI report the need for as much notice as possible to enable us to locate units that would be suitable for the patient should the need arise. So the top image that hopefully you can see here is a national pulse search for any wet units. And at that time, we identified only 3 units across the country, 2 of which would have been suitable for our patient due to the patient being Group B. The next image that you can see is the NFBB stocks, whereby there were a total of 15 R' units available, all Group O. And then a third option for blood provision for this patient is what Reka's already talked about. With enough time and planning from Reka and her team, then we can undergo donor call-up specific for the patient.
Okay, so around the same time as we received the subsequent sample, a rare blood letter was sent to the hospital to advise of the patient's type and the potential delay if requesting blood. So at this point, the medical department liaised with donor sessions to protect appointments for donors with suitable phenotypes. These donations were bled and put on hold so they couldn't be used for another patient, and then processed and held at NHSBT Birmingham. When we were notified that the patient was due to deliver imminently, the red cells were put into what we call our work in progress tray for RCI, which is where our units are held for patients that are currently undergoing cross-matching, but in the end no units were requested for mum or baby at delivery.
Okay, so moving on to case 2. This is again an antenatal patient, 29 years old, first sample in pregnancy, which was received a little bit earlier than the last case, received at 17 weeks. So there is no previous antenatal history known by us on our system, and the initial testing in accordance with BSH guidelines for booking bloods was performed on our automated platform, ABO group, D group, extended RH and K phenotyping, and a full antibody investigation by both BioRad IAT and BioRad enzyme IAT. So the initial results for the case, the patient grouped as B positive. The extended RH and K phenotype showed that the patient was big E neg, K neg, and you should be able to see the panel for the initial antibody investigation results, whereby the full panel with IAT was a pan-reactive picture, no variability in reaction strength, and the enzyme IAT was all negative. So it's worth noting that when you first look at the panel, it does look as though it's just a standard pan-reactive autoantibody, but on closer look, the auto is actually negative, and the controllers all work, so we know that we can accept the results and they are valid. So it's not what is first expected from this reaction pattern. So the results in this case can indicate the presence of an alloantibody to a high-frequency antigen. So like Reka's already mentioned, the definition, the high-frequency antigen is an antigen that's found in more than 99% of a given population. So what's next for us in the lab serologically? What do we need to do next for this patient to resolve the case? We need to look at the reactivity patterns for any clues. We also need to perform extended phenotyping, and we really do need some more clinical information from the referring site, either from the blood bank or from one of the clinicians on the referring site.
Okay, so as Nicci's just said, the results we had, the antibody was reacting by BioRad IAT and this tube IAT, but there was no reactivity by enzyme IAT, and we had uniform reaction strengths. So we're looking at the reactivity pattern, and that can give us clues to what the antibody specificity might be. So first clue, the antibody is not reacting by enzyme. It indicates the antigen's enzyme sensitive, and it narrows down the list of potential antibodies that it could be. The second clue, you've got a uniform reaction strength rather than a variability. So that suggests the presence of a single specificity rather than a mixture. Third clue, hopefully you should be able to see some phenotyping results. The results that we got actually show a fairly standard phenotype. She's not negative for anything that's obviously high frequency. So this lady was Lutheran B positive, she was KPB positive, and she wasn't noticeably negative for anything such as BA or Duffy B or big S and little s. So at this point, we try and look at the clinical information as well. But as Nicci's already said, there was very little given. It would have been useful at this point to have the patient's ethnicity, because this could narrow down again the list of suggestions for the antibody specificity. Just to reinforce that, we've got a little table with a selection of high frequency antigens that are absent in certain populations. So the table shows a very small selection and which populations these antigens are absent in. So it's just a demonstration of how ethnicity, when combined with the other information, can help narrow down the potential list of antibodies that could be present. So, for instance, if you look at the top, the ATA, that's absent in blacks, but it's not enzyme sensitive, so it's not what we're looking for, because the antibody reactivity that we've got showed enzyme sensitivity. Whereas if we're looking at something like the IMB, that is enzyme sensitive. So we've got a selection of populations that's absent in, or can be absent in. So it's about putting the pieces of information together to get a likely candidate. So we did some further testing. We did a monospecific DAT, which was negative. We tested the panel. We tested the plasma, I should say, apologies, with a panel of DTT-treated red cells. So DTT is a subhydral compound. It knocks out some antigens. And so the plasma was negative with this panel. So again, that's another clue that they were negative with the DTT-treated cells. We also have a panel of rare cells here in RCI, which we put the patient's plasma against. It can aid our investigations for high-frequency antibodies. It consists of cells negative for HFAs and also indicator cells that can be used for a range of antibodies, like cord cells, which are negative for certain high-frequency antigens such as ANWJ and STA, and they're weak for other antigens such as I, YTA, Lutheran B. And also there's an in-lieu cell on there, which is weak for things like Indian and NOPS, and can be and negative for Lutheran antigens and ANWJ. So it's using not just the high frequency negs, but the indicator cells as well, all just to pick up to build up a picture. So the results we had indicated that this lady had a possible anti-IMB, but we didn't have the resources here to confirm it. So the sample was sent down to the IBJRL reference laboratory. So red cell reference IBJRL, this is the reference lab for reference labs. They deal with cases from all across the world. They have extensive collections of both cells and antibodies for use in investigations, whether that's for high frequency antibodies or antibodies to low frequency antigens. They also have extensive reagent collections that include enzymes, chemicals, recombinant proteins, and have access to different assays like Maya to help identify antibodies where we cannot work out what may be present in the patient's plasma. So the red cell reference investigation process at IBJRL, they will use the information supplied by the referring laboratory. So copies of the panels that we've done, any typing results that we have, any clinical information as a starting point for their investigation. And they'll put up a small selected panel, which is a 3-cell screen, and a further 2 group O phenotype match cells, a cell of the patient's own ABO group if they're not an ABO, if they're not a group O, an autologous cell, and they're tested by 3 different techniques. So this IAT, enzyme IAT, cell and room temperature. The cell selection is influenced by the information given by the referrer, and it can be shortened if there isn't a lot of plasma there. So the amount of sample that is sent down for them to work with is also a big determinant of what they will actually be able to do. So the initial results that they get from their initial screen inform their further testing. So are the reactions stronger by any one technique? Is there evidence of enzyme sensitivity? Are the reaction strengths consistent or variable? Are there weaker reactions for certain cell phenotypes? Is there any hemolysis present? So Next steps, once they have their initial results, they will use that to inform what they do next. So their experience combined with those results will either lead them to antigen screening, where they pick a panel of antigens to screen for ABID result, based on the ABID results to target the most likely antigens. Or they will go to phenotyping. If the reaction suggests certain blood group systems may be involved, they can type for the relevant high-frequency antigens contained in that system. Enzyme panels, they can use a panel of proteolytic enzymes. So they use papain, trypsin, alpha-chymotrypsin, pronase, and they also put AET in there. And the different enzymes cleave the carrier molecules that contain the antigens at different points. So the reactivity pattern can act as an indicator. So what may be negative with papain may still be positive with pronase and chymotrypsin, or it may be negative for all the enzymes, or maybe positive with only one. It's again about building that jigsaw picture just to see what is the most likely candidate. They can also use recombinant proteins to see if they can neutralize the reactivity. So for things like CR1 related antibodies, Dombrot, leucine antibodies, Sienna or JMH. They'll also use high-frequency antigen-negative cells or null cells. They tend to be used after typing in the targeted antibody screening, dependent on the results that they get. So obviously they're very rare, they're a scarce resource, they don't want to use them unless they have to. And we can also do elution studies, so they make an eluate from phenotype matched cells that are matched to the patient, and then they test that eluate against null cells to see whether the reactivity is still there or to differentiate out complex mixtures.
Okay, so IBGRL red cell reference did confirm the presence of an anti-IMB. So a little bit on anti-IMB. Rake has already spoken about like the rarity of this antibody. It's an IgG class antibody to a high frequency antigen of the Indian system, and the occurrence is 99% in Caucasian populations and 96% in South Asian Indians. They're capable of causing severe and delayed hemolytic transfusion reactions, but as yet no HDFN cases have been reported, and it's thought that the anti-IMB antibodies don't cause HDFN because they've got a capability of binding to the CD44 on fetal monocytes and macrophages, and therefore they've got a blocking effect on the receptor. So in accordance with the SPN 214 and BSH guidelines, for patients with anti-IMB, we need to supply serologically the least incompatible red cells, but antigen negative red cells do need to be considered for strong examples of the antibody. So our patient had a pan-reactive picture of 2+ reactions, so this isn't considered a strong example of the antibody. So this information needs to be used alongside a full obstetric history and bleeding history of the patient, and it was agreed that we need to utilise PBM measures both pre, peri and post-delivery to try to minimise the requirement of blood for the patient. So we need to close monitor the fetus to understand the risk of HDFN and to minimise any intervention in utero, and to also look for any increases in the titration value of the antibody. So the IMB stocks, national IMB negative blood stocks, where there were no wet units available at all, and the national frozen blood bank stocks, there were a total of 12 units that were IMB negative, but only 7 of these would be suitable for our patient when incorporating the ABO and RH type of the patient as well. So preparations for delivery, there's an involvement of obviously the transfusion team of both laboratory, RCI laboratory and the hospital transfusion laboratory, the medical consultants, obstetric team and the antenatal teams. They're all essential in the safe delivery of baby and the management of the pregnancy. So it was the case was discussed with NHSBT RCI consultant, with the consultant haematologist at the hospital and with the hospital transfusion laboratory. and the hospital had requested a total of 2 units of IMB negative red cells in preparation for delivery by C-section. So the plan was to avoid transfusion where possible and to utilise PBM measures, as I've already mentioned. And also a plan in agreement with both consultants was to use ABO, RH and K-match red cells to cover the procedure if required, and to use these alongside IVIG cover for the patient too. And the IMB negative red cells were not to be supplied, both due to the antibody strength in the patient, the likelihood of use for the procedure, and also the rarity of the stock. So it's all about balancing the risks, obviously, with the likelihood of the units being required by the patient for the procedure she's undergoing. And then at delivery, RCI supplied 2 units of red cells prior to the section procedure. And then RCI also supplied a further 2 units of red cells. And it's worth noting this was an on-call request out of hours in the middle of the evening as well. And the patient received B positive, big E neg, K neg blood that was supplied on both occasions with no reactions that we were made aware of. So with both cases, the learning points that we wanted to highlight are that complex investigations can be both time consuming and sometimes really difficult to resolve, and that patient phenotype and ethnicity is a useful indicator, especially if an antibody to a high prevalence antigen is suspected. That blood provision may be difficult and there may be a significant delay, and this is where the teamwork comes in. It's not always due to the presence of a rare antibody, like we highlighted in case 1. It's sometimes due to the rare phenotype of the patient. I've already stressed, and Rake has stressed before us as well, that effective communication and teamwork are essential, and this is both between referring laboratory and the RCI department, and also between hospital clinicians and NHSBT clinicians. So thank you for listening. I do apologise for all the IT issues that we seem to have been experiencing during our presentation. I suppose, are there any questions? We've listed some references there as well. I'm sure our slides can be made available post this session if you weren't able to actually see all of the slides while we were speaking.